Your life. Ma'am, your life.
Yeah. Very good morning and warm welcome to the Women Ophthalmologists Society Residence Program organized by the CG chapter of WOS. So I welcome you all, and now I'm going to introduce our judges. So we have Dr. Swati Tamaskar ma'am. She is a professor in Shri Balaji Medical College, Raipur. Our second judge is Dr. Lipi Chakrabarti. She is professor and HOD in Chandulal Chandrakar Medical College. And the third speaker, we have Dr. Soumya Dalani. She is professor in Shankara Medical College. Now I'm going to introduce our speakers. From MGM Eye Institute, Raipur, we are having speaker Dr. Harsha Golani, and her mentor is Dr. Shubhangi Sharma. The second speaker is Dr. Marisha Singh. Her mentor is Dr. Pratima Sahu. From GMC Rajnandgaon Medical College, we are having Dr. Geetanjali Sharma as a speaker. Dr. Abha Sinha is her mentor. Second speaker is Dr. Swati Sharma. Dr. Yamini Ravte is her mentor. Then the third participant is AIMS Raipur. The speaker is Dr. Sharmila S. and mentored by Dr. Vijaya Sahu. The second speaker from AIMS is Dr. Barkha Singh, and she is mentored by Dr. Madhurya Kela. Our fourth institute is Pandit Jawaharlal Nehru Medical College, Raipur, and the speakers are Dr. Seema Ahuja, mentored by Dr. Swati Jain, Dr. Nikita Behra, mentored by Dr. Monika Singh Thakur, and we are having from SIMS Medical College, Bilaspur, Dr. Arushi Sharma, and she is mentored by Dr. Suchita Singh. And we, as a guest faculties, we are having Dr. Devi Aishwarya Das from Orissa WOS chapter. She is head of Orissa WOS chapter, and Dr. Jimmy Mittal ma'am from Lucknow. Dr. Madhuri Baduria ma'am, she will be joining later on. And we are having Dr. Shweta Walia ma'am from MGM Indore, and she is taking care of the WOS residence program. So now we will start, and I will like to invite Dr. Shweta Walia ma'am to give her talk on WOS care.
So good morning, everyone, and welcome to the Chhattisgarh chapter of WOS resident competitive session. I am Dr. Shweta Walia. I am Professor Ophthalmology at MGM Medical College, Indore, and National Coordinator for these resident sessions. This event marks a significant milestone in empowering women in ophthalmology. It provides a unique platform for residents to showcase their knowledge, skills, and innovative thinking. We owe a great deal and gratitude to Dr. Madhu Badoria and Dr. Mohita Sharma, the visionary behind this initiative, and to Dr. Meenakshi for her leadership in organizing Chhattisgarh chapter state level competition. To our residents, today is your day to shine. Your hard work and dedication have brought you here, and this competition is an opportunity to demonstrate your clinical acumen and share your innovative
Hello.
of India. Under the flagship of WOS at a very nominal registration fee. The WOS shall arrange the stay and travel of the candidate. The courses that we are planning to come up with are the phacoemulsification, ICL, medical retina, lasers and intravitreal injections, myopia clinic, and dry eye clinic, etc. We shall soon start the registration process. So be in touch, and we plan to learn and grow together and pave the way for future success. Thank you, and let the competition begin. Thank you.
So here we start with our first competitive session. And now I would like to invite Dr. Amrita Verma. She is executive of WOS, and At present, she is assistant professor in Pandit Jawaharlal Nehru Medical College. So welcome, Dr. Amrita Verma, and now you should take over to the competitive session 1. And I request the judges to start their compiling of the marks. Okay. So over to Dr. Amrita Verma.
Dr. Meenakshi, I hope I'm audible. Okay.
Yeah, you're audible.
Okay. So now, good morning, everybody. And the stage is all set now to begin the first competitive session. And in this session, we are joined by Dr. Swati Tamaskar ma'am, Dr. Lippi, and Dr. Soumya Dulani ma'am as our judges. The institutes participating in this session are the MGMI Institute, GMC Rajnandgaon, and AIMS Raipur. So for the first talk, I would like to invite Dr. Harsha Goklani, being mentored by Dr. Shubhangi Sharma. Could you please put on your presentation and start?
Yes, ma'am. Hello.
You're audible, Harsha.
Hello,
You
may
can
I
start.
start?
Yes.
Okay. Good morning, respected judges, respected seniors, and my colleagues. So, a 52-year female presented with chief complaint of pain and redness in both eyes since 15 days, which is sudden in onset, non-progressive, mild, and present throughout the day with associated with redness. Patient had similar complaint in the past and was found with raised intraocular pressure, treated with brimonidine and timolol eye drop twice a day. The patient was relieved with it and discontinued the medication. There is no significant past history. On ocular examination, the visual acuity is 20 by 20 and N6 with pinhole. Dry eye retinoscopy was done. The external examination is within normal limit with full, free, and painless ocular motility in all the directions. The slit lamp examination shows a VH grade of 1 in both the eyes, and the intraocular pressure is 22 and 24 millimeters of mercury with Goldman applanation tonometer under 2 anti-glaucoma medication. A four-mirror gonioscopy was done under topical anesthesia, and the angles were closed in primary position, not opening on indentation in both the eyes. Undilated fundus shows normal disc in the right eye with cup disc ratio of 0.3 and cup disc ratio of 0.65 in the left eye. So my provisional diagnosis will be, if the anterior chamber is shallow and the intraocular pressure is raised with closed angles, the left eye is primary angle closure and the right eye also shows disc changes, it is a primary angle closure glaucoma. The patient was done a peripheral iridotomy and was advised topical steroids to reduce the inflammation for 2 weeks in tapering dose and was continued with the same anti-glaucoma medication. On following up the patient at 2 weeks, the visual acuity is 20/20 by N6 in both eyes with glasses. The intraocular pressure is 16 millimeter of mercury under 2 anti-glaucoma medication. The VH grade is still 1 and the iris shows a PI patent at 3 o'clock with few discrete scattered lenticular opacities in the lens. So we did a dilated fundus evaluation, which shows a significant choroidal folds in the mid-periphery and a small pigment epithelial detachment is seen inferior to the fovea. A similar picture is seen in the left eye, which shows choroidal folds in the mid-periphery. So my differential diagnosis is a secondary angle closure with posterior scleritis or secondary angle closure with VKH disease. We ordered a B scan to differentiate between two. The first scan shows increased scleral thickness. Here we can see a fluid pocket in the subtenous space suggestive of subtenous fluid, and a similar picture is seen in the other eye also. So this suggests the presence of posterior scleritis in both the eyes. We did a FFA to see the presence of disc edema. This is a um, early venous phase. This is mid venous phase, which shows a pooling of dye inferior to fovea and multiple pinpoint leaks in the periphery, which are also seen in the late venous phase, and this is a pooling of dye. The left eye shows similar picture. Also, we can see choroidal folds in both the eyes. There are multiple pinpoint leaks in the other eye also. So my final diagnosis is a secondary angle closure with posterior scleritis, early cataract, and both eye status post YAG PI. We ordered blood investigations to find out the cause of posterior scleritis, and it was found that anti-DS DNA is positive. The patient was referred to rheumatologist for treatment and started on rheumatology treatment and steroids. So at final visits, my patient has no symptoms. The intraocular pressure is under control and the choroidal folds have resolved. So the take-home message is that it is mandatory for every patient undergoing a YAG PI. A dilated evaluation should be done to find out the secondary cause, if any, and also a patient presented with pain in ocular movement proptosis, a differential of posterior scleritis must be kept in mind. There are various case reports which shows bilateral posterior scleritis presenting as acute primary angle closure glaucoma, which was reported in 2021 recently. Um, Thank you. Thank you, respected judges, and my mentor, Dr. Shubhangi Sharma, ma'am.
So, thank you, Dr. Harsha, and that was right on time. So that is good. You stuck to your time. So now I would like to invite the judges to ask their queries and questions. Swati ma'am, it's muted. We cannot hear you.
Hello, Amrita. Is it audible?
Yes, yes.
Dr. Harsha, I want to know what's the pathophysiology of posterior angle closure glaucoma because of posterior scleritis, how it happens?
Yes, ma'am. So in posterior scleritis, there can be glaucoma also because of open angle or closed angle. So the most
Mm,
common reason is the inflammatory cells which block the
mm,
trabecular meshwork, which leads to
mhm,
TM obstruction. And the
mhm,
other, we have seen that as there is increased scleral thickness, it may
mhm,
oppose the vortex vein directly, and also
mhm.
it may push the iris diaphragm forwards, leading to angle closure.
Total angle closure you have mentioned na, in both eyes.
Yes, ma'am.
And it responded to your PI, only PI, with two anti-glaucoma, isn't it?
Yes, ma'am.
Okay.
It was a nice presentation for you, and it was in the time also. And any other investigations you will suggest for the posterior scleritis?
Yes, ma'am. We can also do a optical coherence tomography. It can
Mm.
show subretinal fluid in posterior scleritis, and we can also do uh, a UBM.
Okay. Okay, that's good.
So I think we can open
Yes,
it
yes,
to
you
the
can
senior
proceed.
members in the audience also if they want to ask any questions. So, okay, I think there are no more questions for Dr. Harsha. So thank you so much, Dr. Harsha. Now,
Thank you, ma'am.
I would like to call upon the second speaker, Dr. Marisha Singh, who's been mentored by Dr. Pratima. Could you please start your presentation?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Shall I start?
Sure, please go ahead.
Shall I start?
Yes, please start.
Okay. Good morning. I am presenting my case of 62-year-old female who is housewife presented on 4th of October 2023 with chief complaint of diminution of vision in right eye since 2 months and pain in the right eye since 20 days. Diminution of vision in right eye was gradual in onset, progressive and associated with pain and redness since 20 days. The pain in right eye was gradual, progressive and mild in intensity, persistent throughout the day and not associated with ocular movement. There was no history of any previous ocular trauma, no history of watering, no history of photophobia, no history of discharge, glare and halos, and no history of headache. There was history of right eye attempted cataract surgery elsewhere 2 months back, and the surgery got deferred due to unknown reason. Patient was putting some eye drop, details not known. There was no family history of glaucoma in immediate and distant relative. It was asked retrospectively. Personal history was not significant. No history of any systemic disorder. Patient was well oriented to time, place, and person. No pallor, ictrocyanosis, or clubbing. On ocular examination, visual acuity for right eye using logmer chart for distance is PL plus PR inaccurate, and for left eye is 20 by 200. With pinhole, there is no improvement in right eye, and in left eye 20 by 100. Near vision with reduced Snellen chart at 33 centimeter for right eye was less than 6 by 36, and for left eye 6 by 9. External examination was essentially normal. This is the slit lamp examination picture of the right eye, which was showing the lid was normal. In conjunctiva, there is conjunctival and circumciliary congestion. Superiorly, we can see there is retracted conjunctival fold. The cornea appears to be normal in shape and size. In cornea, there was a stromal edema present, and on endothelium, cortical matter, cortical lens matter, and the blood clot was stuck on endothelium. And inferiorly from 7 to 8 o'clock, there is linear incision on cornea with iris tissue adhere on it. The AC was flat with fluffy cortical matter on AC and blood clot on inferiorly. The pupil was mid-dilated and non-reactive. The iris and iris superiorly from 10 to 12 o'clock, there was posterior synecdoche present, and inferior iris detail was not seen due to presence of fluffy cortical matter. And the lens was total intermittent white cataract. IOP with Goldman applanation tonometer for right eye was 36 mm of Hg. In left eye, all other findings were normal except lens, which was NO3, NC3, P3 cataract, and the IOP was 10 mm of Hg. As the IOP was raised, we performed gonioscopy. In left eye, the angles were open primarily, which was opening on indentation till scleral spur, and in right eye, it was deferred in view of hazy media. Dilated fundus examination was not done in view of occludable angle in left eye. In right eye, there was no view of fundus. The undilated fundus examination of left eye saw media hazy due to cataract and retina was on. So these all findings which are present in slit lamp in cornea, there was linear incision from temporal 7 to 8 o'clock, puffy cortical matter in AC, blood clot inferiorly, and total white intumescent cataract with intraocular pressure 36 mm of Hg. These all findings are pointing toward this, that there was attempted cataract surgery. So my differential would be right eye traumatic cataract, status post complicated cataract surgery with lens-induced glaucoma, or with it may be due to primary angle closure glaucoma also, and in right eye mature senile cataract with lens-induced glaucoma, or maybe primary angle closure glaucoma. So we performed investigation A scan. This was done in a phakic mode, and SRKG formula was used for IOL power calculation. This was the standardized B scan of right eye, which was showing echo-free vitreous cavity and retina was on. On immersion based scan, echogenic lens, which was suggestive of cataractous lens, and PC appears to be intact. Posterior capsule status was intact. My final diagnosis would be right eye traumatic cataract with lens particle induced glaucoma, left eye senile cataract, and left eye primary angle closure suspect, or maybe primary angle closure glaucoma. So we gave treatment IV mannitol 200 ml
So 4 minutes are up for you.
And right eye prednisolone acetate, and right eye atropine sulfate. And we plan OD cataract surgery plus minus intraocular lens plus synecholysis, and IV mannitol preoperatively 100 ml, and left eye laser YAG PI was advised. And post of day 1 picture. In right eye, there was total glaucomatous cup was seen after dilated fundus examination. This was the picture of third visit.
OS last laser peripheral iridotomy was done on 1 week after cataract surgery. In left eye, the disc was CDR ratio of 0.5 with healthy neuroretinal rim. So my take-home message will be, under no circumstances should the ophthalmologist subject a patient to half-completed or compromised surgery because of a lack of expertise or proper infrastructure. Thank you.
Okay, thank you so much, Dr. Marisha. That was a very good case, and I would like to invite the judges for question and answers.
Dr.
Dr.
Marisha.
Yes, ma'am.
Dalipy, continue, please.
Yeah, I would.
From Manisha, it was nice presentation, and so it means your presentation was slightly hurried. So your speaking was also slightly hurried. So
Know that what was the status in left eye and why this glaucomatous optic atrophy that happened in right eye so fast, means for how many weeks or months that angle closure glaucoma status was there, that lens particle glaucoma was there. Thank you. So two
Yes, ma'am.
questions.
Ma'am, the attempted cataract surgery was done 2 months back, and the patient presented after 2 months. So this total glaucomatous optic atrophy takes almost 2 months. And in left eye, there is on gonioscopy, there is angle closure suspect, and the disc was healthy. So left eye, there is primary angle closure suspect with senile cataract, and in right eye, it was lens-induced glaucoma.
What I wanted to ask is that the surgery was deferred, you're telling, for how many days or months it was deferred? The patient was taken to table and it was deferred, or what happened?
Yes, ma'am. The surgery was deferred due to some unknown reason, and then patient presented to us after 2 months.
Okay, thank you.
Yes, ma'am.
okay.
So, any more questions from the judges? Dr. Swati ma'am, you wanted to ask something, I think.
Yeah. Actually, the presentation was very hurried, and means so it was okay, but otherwise, and she presented nicely. And usually the traumatic cases we also see, and like a glaucoma and trauma both are there. So it's good for her to learn the things. That's all.
Okay, thank you, ma'am. Dr. Soumya ma'am, do you want to ask something?
Just I want to ask Marisha, what can be
Yes,
the situation she can imagine? What are the conditions in which these surgeries, cataract surgery on table are deferred? Any idea? You are first year.
yes, ma'am. Ma'am, this
Then
surgery was performed elsewhere, but we can suspect, as there was primary angle closure suspect in the left eye, so there is chances that other eye angle will also be shallow. So instrumentation problem will be there during surgery, and other causes.
instrumentation.
Yes, ma'am, due to shallow anterior chamber, there may be difficulty in instrumentation. Or second, patient may be intra-op raised IOP may be there.
Yes.
Patient might be uncooperative. These all I can think of.
Yeah, Marisha, since you're in first year, so another basic question to you: what are the other causes of secondary angle closure glaucoma you can think of? 3 to 4 causes at least.
Yes, ma'am. Ma'am, secondary angle closure glaucoma can be due to complicated glaucoma due to uveitis or iridocorneal endothelial syndrome, neovascular glaucoma due to suprachoroidal hemorrhage,
aqueous misdirection syndrome.
effusion, Yes, ma'am.
Yeah, good. So neovascular glaucoma you mentioned, that is one of the most common causes in India and also abroad. Okay, thank you, Marisha.
Yes, ma'am.
Thank you, Marisha.
Thank you.
Okay, thank you so much, Dr. Marisha. And thank you, MGM Institute. These were the two participants from MGM. And now moving on, I would like to invite Dr. Geetanjali Sharma to be ready with her presentation. Her mentor is Dr. Abha.
Thank you, ma'am. Shall I start, ma'am?
Yes, please go ahead.
Good morning, everyone. Today I am presenting a case of photokeratitis with multiple iron particle embedded in the cornea due to welding arc. Presenting complaint was a case of 48-year-old male resident of Ranjangaon, welder by occupation, presented in eye OPD with complaint of severe pain, foreign body sensation, intolerance to light, burning sensation, blurring of vision, excessive watering, unable to open both eyes since 2 to 3 hours while during the welding work. History of presenting illness: patient was apparently all right in the morning, then he got exposed to flash burn for 30 seconds while doing unprotected welding due to short circuit of wire. He developed severe pain which was acute in onset and pricking in nature. Patient presented with complaint of foreign body sensation, photophobia, sudden diminution of vision, burning sensation, excessive watering, redness, and patient was unable to open his both eye following exposure to welding light. No history of halogen lamp use, solar eclipse, mountain climbing, fire burn, any drug intake exposure, any recent infection, contact lens use, any topical drug use. Past history: no history of any significant chronic disease, personal history, family history, no significant welder by occupation, general and systemic examination, cardiovascular system, respiratory system, GIT, all are within normal limits. Local examination, flash burn involve the periorbital area, nose and face. Facial erythema also present in slit lamp view at the time of presentation. The multiple foreign body foreign body iron particle embedded in the cornea, and cornea is hazy after 1 to 2 hours at the time of presentation. Self peeling of superficial layer of cornea started. In ocular examination, visual acuity in right eye 1/60, in left eye 2/60. Size of eyeball normal in both eye, normal in position, orthophoric and alignment. Eyelids are matted and burned. Upper eyelid edema and erythema present, and lower eyelid edema and erythema present in both eyelids. Rhoplast negative, palpebral aperture decreased. In bulbar and palpebral conjunctiva, in both eye, conjunctival and circumciliary congestion are present. In palpebral, conjunctival congestion with multiple iron particle present. In fornices, foreign body and multiple iron particle present. Size and shape of cornea is normal. Surface corneal edema with multiple foreign body embedded in right and left eye. Transparency is hazy and sensation are present. Vascularization absent. In anterior chamber, content and depth are not visible in right eye and normal in left eye. Iris texture pattern details not visible in right eye and in left eye, normal in superior half of iris. Then management, our primary aim is to relieve discomfort, prevention of control inflammation, secondary infection, ulceration. Eye was irrigated with normal saline. Foreign body present in palpebral conjunctiva will remove the sterile disposable hypodermic needle after instilling topical anesthesia. Pharyngeal conjunctiva was wiped with cotton tip applicator, moistened with topical anesthetic to remove any foreign body. Oral analgesic, aciclovir SP and chimeral 4 For 5 days, oral antibiotic doxycycline to inhibit neutrophil activity and reduce chances of ulceration, and tablet vitamin C for epithelial wound healing. Topical antibiotic eye drop moxifloxacin, and eye ointment chloramphenicol polymyxin B VD for 5 days. Lubricating eye drop CMC 1% hourly for 5 days. Eye ointment hydroxypropyl methyl cellulose ophthalmic gel VD for 5 days. Cycloplegic eye ointment atropine was used, and ointment silver sulfide diazine BD for 5 days for burn injury over periorbital area and face. Overnight eye patching with lubricating eye ointment,
So
hydroxypropyl
your
methyl.
time is up, Dr. Gitanjali. Please
Ma'am,
wrap up fast.
after 2 days of conservative management, this finding seen, and then my differential diagnosis is halogen lamp use, solar eclipse, mountain climbing, fire burn, any drug intake exposure, any recent exposure, chemical exposure, viral conjunctivitis, contact lens wear, and after first follow-up, cornea, all finding within normal limit, erythema of face and cornea is clear, and in first follow-up, distant vision is 6/6 in both eye, near vision N6, color vision normal, and fundus within normal limit. Discussion. Photokeratitis is a painful eye condition, can develop after unprotected exposure to ultraviolet rays, and cornea is transparent and transmit light in the visible spectrum but will absorb light in the UV spectrum. The epithelial UV absorption potentially serve as a protective role for the underlying stroma and endothelium, but causes in the process damage and apoptosis, which result in delayed sloughing of epithelium. In our study, patient presented the clinical feature of photokeratitis 2 to 3 hours after unprotected exposure of welding associated with multiple conjunctival as well as foreign body embedded in it. Patient reported easing of symptom 2 to 3 days after treatment and was symptom free after 1 week of treatment. Patients were treated with abundance lubricating, and none of the study reported photokeratitis along with multiple conjunctival and corneal foreign body embedded, which was unusual in our case. Conclusion: photokeratitis is a preventable disease with proper UV protection. Patient with recreational UV exposure should wear proper fitting sunglasses which have appropriate UV blocking property. Many eye injury are effectively managed in the workplace, but effort to prevent injury are needed worldwide. Person with occupational UV exposure such as welders should be educated in their factory and working place by information, education, and communication. For welders, specifically have a full face shield with adjustable side level is necessary for adequate protection. The key to accurate eye assessment is thorough and systemic examination of eye, being alert for the vision threatening but less common injury that will need to definitely managed by ophthalmologist. Thank you. These are my references. My mentor, Dr. Abbas Ma'am. Thank you, ma'am.
Yeah. Okay. Thank you so much, Dr. Gitanjali. And I would again request everybody to please stick to your time. And now I invite the judges one by one to please go ahead and ask the questions.
Gitanjali, can you define what is photokeratitis?
Yes, ma'am. Photokeratitis is a painful eye condition which can develop after unprotected exposure of UV rays like welding light or solar halogen lamp or reflection of snow known as snow blindness and germicidal UV lamp.
And how much time it will take normally to heal a case of photokeratitis?
Ma'am, 48 to 72 hours.
Why? That's what I'm asking. Where it affects? Which layer is involved? God.
Ma'am, it involves superficial layer of cornea.
Which layer? Yes, you're right.
Ma'am, epithelium.
Yes. How much time epithelium take to heal?
Ma'am, 48 are.
Sure.
48
Okay, you have given antibiotic locally.
Yes, ma'am.
Why?
Eye drop. to prevent secondary bacterial infection and to reduce inflammation.
Okay. Okay.
What are the layers of the cornea?
Ma'am, first layer is outermost epithelium, second is a Bowman's layer, third is a stroma, fourth layer is a Duas layer, and fifth is a descent membrane, and then last is endothelium.
Oh, good.
About the Birmingham eye trauma terminology system. Can you tell us about it? BETTS.
Eye trauma classification system, ma'am.
Yeah, there is something like open globe and closed globe trauma.
Ma'am, your audio is very faint. Lippy, ma'am.
Okay,
BETS
fine.
classification, Gitanjali.
Yeah, BITS classification.
Sorry, ma'am.
Yeah, it's okay. And what are the most common trauma, ocular trauma that you find in your ophthalmology practice? Photokeratitis is not that common, right? So what are the most common ocular trauma that you see in your ophthalmology practice? What are the common types? You see mechanical injury or chemical injury? What do you see most common? I'm audible, Amrita?
Yes, ma'am, you're audible. You're audible.
Yeah. Okay, thanks, Gitanjali.
Okay. Thank you so much, Dr. Geetanjali. I think we're done with the questions now. And now I would like to invite the second participant from GMC Rajnandgaon, Dr. Swati Sharma, and her mentor is Dr. Yamini Ravate. Yes, you can start your presentation, Dr. Swati. Is there an issue?
Good morning, ma'am. Am I audible?
Yes, you're audible.
Okay. Good morning, everyone. Today I'm going to present a case presentation on ocular manifestation of pituitary macroadenoma.
Could you please put this on slideshow?
Sure. Is it visible, ma'am?
It is okay. Just continue. It is fine. Okay, just continue it.
Uh, It's a case of 58-year female presenting with complaint of headache, peripheral vision loss, double vision, and difficulty in near vision since 6 months. History of presenting illness. Patient was apparently all right 6 months back. Then she developed episodes of severe headache, which was frontal in location and acute in onset. She had difficulty in vision in superotemporal quadrants, which gradually progressed to bitemporal hemianopia. She had double vision on seeing from both eyes for far distance in all gazes, and she had difficulty in convergence on seeing near objects. Past history, personal history, family history were within normal limit. General examination was also within normal limit. Systemic examination was also normal. In local examination, normal head posture, facial symmetry maintained, ocular symmetry, late retraction was present in left eye. This was photograph of the patient showing late retraction in left eye. Ocular examination. Distant vision was 6.9 in both eyes. BCVA was also 6.9, not improving with pinhole. Her color vision was normal for both eye. In field of vision, on confrontation test, she showed bitemporal hemianopia. Extraocular movement in right eye was restricted in all direction, and in left eye it was normal. Eyeball size, position, alignment were normal. In eyelid, the left eye was slightly retracted and touched limbus. Upper lid was touching limbus, and palpebral aperture height of left eye was increased. Conjunctiva bi-headed PTR present in left eye. Cornea transparency sensation were normal. Antechamber content was clear and depth normal. Iris texture pattern maintained. Pupil was round, sluggishly reacting to light in both eyes, and lens had immature senile cataract. Fundus examination was within normal limit with 0.2 CDR in both eyes. On diplopia charting, with both eyes, she showed horizontal diplopia in all direction of gazes. In CNS examination, optic nerve showed sluggishly reacting pupil in both eyes. Oculomotor nerve, trochlear nerve, and aberration nerve, right side palsy. Trigeminal sensations were maintained. Facial nerve examination within normal limit. NCCT head and orbit showed cellular and supracellular calcified mass appears to represent pituitary macroadenoma. DD include extrinsic lesion like paracellular meningioma, craniopharyngioma, paracellular ICA aneurysm, intrinsic lesion like glioma, demyelinating lesion, inflammatory lesion. Non-chiasmal causes can be tilted nerve, atypical glaucomatous optic neuropathy, trauma with chiasmal contusion, or hydrocephalus. This is a relation of chiasma with pituitary gland in mid-sagittal section. There is coronal section showing relation of chiasma with cavernous sinus. Investigations, these were investigations, all were within normal limit, except NCCT head orbit showed pituitary macroadenoma. Patient summary. Patient presented with frontal headache with normal visual acuity with bitemporal hemianopia, horizontal diplopia in all gazes for a par distance and restriction in convergence in 6 months, suggestive of mass effects. No history of trauma, ocular surgery, and facial pain. NCCT head and orbit showed cellular and supracellular calcified lesion of this 4.3 into 3.5 into 3.3 cm, suggesting pituitary macroadenoma. Treatment modalities can be observation, medical therapy, surgery, radiotherapy, and ophthalmological monitoring. Conclusion. Pituitary macroadenoma are benign tumors that commonly diagnosed as incidental finding on imaging, or patient may present initially with peripheral vision loss or headache. Eye clinic is therefore patient's first point of care. By understanding clinical signs associated with pituitary adenoma, eye care providers can ensure early diagnosis, guide treatment, and set reasonable expectations. My provisional diagnosis was non-functioning pituitary macroadenoma presenting with ocular manifestations. Thank you. My mentor is Dr. Yamini Rautan.
Thank you, Dr. Swati. And the ball is now in the judges' court. Please go ahead and ask your questions.
The size of the tumor was around 4 into 3, and how much it is, Swati?
Yes, ma'am. It was 4.3 to 3.5 into 3.3 cm.
Why you are saying it is non-functional?
Ma'am, because she didn't had any systemic features of hypopituitarism of
You have
any
undergone the hormonal test or anything else? Any other investigation?
No, thyroid is waiting.
Okay, hormonal means any other hormonal related to
Like thyroid.
Ma'am, functional macroadenoma can present as a hypoprolactinemia or hypothyroidism or adrenal crisis. Yes, ma'am. But here she didn't had any systemic features.
So what is the prognosis of this patient? What do you think about, I am talking about only ophthalmic manifestation, how they will improve or not, and how you will manage?
Ma'am, as this is a macroadenoma, so it has this suprasellar region affected chiasma, but her visual acuity is normal, 6/9. And a diplopia is due to compression caused by compression to intracavernous part of 3, 4, and 6 cranial nerves. So, if macroadenoma is removed surgically, the compression can be relieved, and she can have improvement in her double vision. And her visual acuity is already 6/9. So, visual prognosis can be good, but due to large size of adenoma, it can has complications during surgery.
And why it is bitemporal hemianopia? What about it?
Ma'am, she complained of first superior quadrantopia in both eyes due to first involvement of lower nasal fibers of chiasma, and afterwards she developed progress to bitemporal hemianopia due to involvement of upper nasal fibers as well, which are in upper position than lower nasal fibers.
Means which part of visual pathway mainly we are talking about?
We are talking about anterior chiasma, ma'am.
Okay. Okay, thank you.
Swati, do you know about pituitary apoplexy?
Yes, ma'am. Ma'am, pituitary apoplexy is a hemorrhage or infarction in pituitary gland in an undiagnosed case of pituitary adenoma. It is more common in pituitary macroadenoma, especially when it is of large size. But as the visual acuity of patient is 6/9, and she don't have facial pain, so pituitary apoplexy is unlikely.
What are the symptoms of pituitary apoplexy?
Ma'am, yes, ma'am. Ma'am, for pituitary apoplexy can present with systemic features like pituitary shutdown or hypopituitarism, and ma'am, it has risk factors like it can happen in pregnancy, obstetric complications, and in old age with large pituitary macroadenoma. And it presents as visual acuities in PR range, and there is a facial pain accompanying it.
Yeah, Swati, nice to know. But what I wanted is just the answer. It's a triad of headache, ophthalmoplegia, and visual
Yes,
fielding.
ma'am. Okay.
Okay. So the second question is causes of binasal hemianopia.
Binasal. There.
Okay, where will you have the lesion if you have binasal hemianopia? Where do you think the lesion will be? Visual tract, कहाँ पे lesion रहेगा?
Temporal fibers will be affected in both sides.
Yeah, the optic chiasma it may be. Okay. Okay, thank you, Swati.
Thank you, ma'am.
Okay, Swati ma'am, do you want to ask any questions? So that was it from GMC Rajnandgaon, and I thank the participants. Now moving on, we have next participation from AIMS Raipur. The first participant is Dr. Sharmila and being mentored by Dr. Vijaya Sahu. Please start your presentation.
Good morning, ma'am. Am I audible?
Yes, yes, you're audible.
Yes, ma'am. Just a second. Good morning, everyone. My case was of a 19-year-old female who presented to us with complaints of generalized weakness and breathlessness for 12 days, blurring of vision, pain and redness in right eye for 4 days. The patient was in her usual state of health until 12 days back when she developed generalized weakness, breathlessness, and giddiness. For the above complaints, she consulted elsewhere where she was found to be severely anemic with a hemoglobin of 3 grams per deciliter. She was hospitalized in the previous institute and she received 6 units of PRBC, where 1 unit was transfused on each day. Following the 6th blood transfusion, she developed high grade fever and chills on the same evening of transfusion. The following day, when the patient woke up, she noticed severe pain, redness, and swelling and watering in the right eye, for which she was conservatively managed for 2 days and later referred to us for further management. There was no significant history of previous ocular trauma or surgery, any topical medication use, intravitreal injection, or intravenous drug abuse previously. Patient gives a significant past history of prolonged menorrhagia for 6 months. There was no significant personal history. The patient presented to us in the emergency room where we found out she was poorly built, poorly nourished, with a body weight of only 40 kilos and height was 138 centimeter. She was kind of short stature too. Her vitals were stable and she was afebrile when she presented to us. Systemic examination of central nervous system, cardiovascular and respiratory system were within normal limit. However, per abdominal examination revealed a hepatomegaly and a splenomegaly. When we examined the right eye, there was no perception of light at all. However, left eye, the visual acuity was 6/6, and all ocular findings were within normal limit except for pallor and icterus in left eye. When we examined the right eye, I could find there is severe lid edema with matting of lashes, diffuse conjunctival congestion, and chemosis. And the corneal shape was completely distorted with areas of corneal thinning, impending perforation, corneal opacification, and whitening. All these features suggested of corneal melting. However, the extraocular movements were within normal range and full. Since the cornea was hazy, rest details could not be assessed. So a gentle B-scan ultrasound was performed where we found out multiple hyperechoic opacities in the vitreous cavity, a hyperreflective band attached to the optic disc posteriorly, and a choroidal thickening. All this led us to the diagnosis of endophthalmitis. So we made a probable diagnosis of right eye endogenous endoph secondary to blood transfusion. Since the patient's general condition is extremely poor, we started her on empirical antibiotics of ceftriaxone and vancomycin intravenously. Simultaneously, a panel of blood investigation was sent to rule out any septic foci within the body. We found out her to have a low hemoglobin, a low platelet count, and a microcytic hypochromic blood picture with a race reactive protein as well as ESR. Her systemic workup for ultrasound per abdomen were everything within normal limit. Similarly, a CCT brain and orbit revealed for right eye endoph and rest all findings within normal limit. So the patient underwent right eye evisceration and the wound was healthy and discharged. However, patient came back to us 2 days following the discharge with severe purulent discharge, etc. However, we received the blood reports and the culture reports which are sent from eviscerated sample, which showed us a rare organism of Aeromonas hydrophila resistant to cephalosporins. Based on sensitivity, we started her on meropenem. That is when she started responding and the wound started to heal. So my final diagnosis is a rare case of Aeromonas hydrophila endogenous endophthalmitis secondary to blood transfusion. Thank you.
Thank you so much. That was a very good presentation, keeping to your time. And I ask the judges to please go ahead and ask their questions.
Yeah, Dr. Sharmila, it's a really very good case and good presentation also. What you're saying, it is because of blood transfusion? What are the most, this is a very rare organism, no? It's
Yes, ma'am. Ma'am, thing is, since she's already immunocompromised, plus she received 6 blood transfusion, and based on her history and typical history and presentation, we just had a differentials or a thought of blood transfusion may be a cause. So we did a panel of investigation to rule out any septic foci, be it ultrasound, abdomen, pelvis, echocardiography was also done, CCT brain orbit was done, and even we
what
performed
was
a
this
LDH.
CBC report? CBC report?
Yes, ma'am. CBC report revealed a low hemoglobin, a normal leukocyte count, and a low platelets. Ma'am, plus she was diagnosed here as thalassaemic minor patient also.
That's what I was
Yes,
asking.
ma'am. Yes, ma'am.
A case of some. Means it was a case of immunocompromised patient.
Yes, ma'am. Actually, patient was never diagnosed. She never knew that she had some blood disorder until she developed symptoms because of low hemoglobin. So there were multiple risk factors. She being immunocompromised and receiving multiple blood transfusion. Ma'am, that too she received 1 pint every single day. In a continuous of 6 days, she had received 6 pints of blood.
Can you put
So,
some light on this organ?
Aeromonas, which group it comes?
Yeah, that's what
ma'am,
I'm
it's a
asking.
gram-negative bacilli. Usually, it's a facultative anaerobic organism, and mostly it's an oxidase positive. It is a very atypical organism infecting human beings. Mostly, it is a fish pathogen. It's an aquatic pathogen.
Yeah, it's an animal pathogen. Yes.
Yes, ma'am.
Yeah.
So you had the culture and everything for this aeromonas?
Yes, ma'am. So actually, when we sent for gram stain, within 2 days we got a report that it's a gram-negative organism, and somewhere there was a confusion between pseudomonas. So that is when culture sensitivity was done, which revealed, ma'am, this is a blood culture report which showed a hemolytic colonies and typical Aeromonas hydrophila colonies, which are yellowish, creamy white raised colonies and beta hemolyte. Simultaneously, when we had done the culture sensitivity reports, even that helped in differentiating it from pseudomonas.
Good.
Okay. Yeah.
Sharmila,
Okay.
Yes, ma'am.
what does Aeromonas generally cause? Like endophthalmitis is not so common.
Yes,
So which
ma'am.
system it affects?
Ma'am, mostly in literature, what I found is it's commonly affect gastrointestinal tract, commonly, especially in immunocompromised patients and those with malignancy. Some of the case reports are known to affect adenocarcinoma of the colon and even gallbladder carcinoma. In some of the patients, it has been reported.
So in abdomen, did you find anything for this patient?
No, ma'am. Except for hepatomegaly and splenomegaly, most likely due to thalassemia and prolonged hemolysis. Other than that, there was no septic foci or any abscess within the liver or spleen, ma'am. And neither the intestines were also normal.
Okay, so what happened to that patient? You started her on meropenem and tobramycin. Then
Ma'am, actually, on the day she presented to us, since her general condition was poor and the vision was PL negative, we took permission from medicine and respective departments, and for the best of the patient's health, we decided for evisceration. However, we had started her on IV ceftriaxone since we had no clue about the organism. But we thought the patient would respond well and she would be better. But after discharging her, she came back with severely infected wound again because she didn't actually respond to ceftriaxone. This was the condition of the wound post discharge. So then by 7 days, it was exactly 7 days when she presented to us. That is when we received the culture sensitivity reports. So we shifted the antibiotics, simultaneously did wound debridement and dressing every day. That's when she responded. And currently, ma'am, she's doing good. This is a socket 3 months after surgery, and now she's being planned for prosthetic eye, ma'am.
yeah, this already you had shown in slide. Actually, the cases they go so fast that maybe for 3 seconds if we are out, we miss a slide. Okay.
Yeah.
Thank you, Sharmila.
Yes, ma'am. Thank you.
Okay. Okay, thank you so much, Dr. Sharmila. And now I invite upon Dr. Barkha Singh under Dr. Madhuri Akela to please give her presentation.
Good morning, ma'am. Ma'am, can you see my presentation? Ma'am, can I start? Good morning, ma'am. See my presentation? I start?
Yes,
Hello.
but it's not there on the screen. Yes, please start. But
Okay, ma'am. Good morning, ma'am. I'm presenting a case of 50 years old female from Raipur. She
hold on, I
presented to
can't
emergency.
see. Wait, Dr. Barkha. It's not there on the screen.
Yes, ma'am. Okay, ma'am.
Just share your screen first. before you start your presentation.
Is it visible, ma'am, now?
No, your presentation is still not visible. So you have to go to the share sign, which is visible in the bar, and then you have to press share and then share your presentation here. That will share your screen.
Okay, ma'am.
Yes, now it is visible. And just
Okay,
go to
ma'am.
the slideshow now and yeah, put it on the slideshow mode.
Good morning. I'm presenting the case of 50 years old female from Raipur. She came to emergency department with chief complaints of diminution of vision, pain and redness in the left eye for 12 hours and vomiting for 2 to 3 hours. Patient developed all the ocular symptoms which were sudden in onset and non-progressive in nature. There was associated nausea, vomiting and headache, and there was no history of trauma. There was no history of similar complaints in the past, and the patient says there was history of bilateral eye cataract surgery with relatively poor visual gain in left eye. There's also history of multiple episodes of transient obscuration of vision in the left eye, and also multiple episodes of unconsciousness
Your
lasting less.
slides are not moving, Barkab.
Um,
Just go down
and
with
also
your slides also, please.
multiple transient episodes of unconsciousness.
Only the first slide is visible.
Just click on the first slide once. उस पे click करो. Yeah, now you keep going down.
Okay. There's history of multiple transient episodes of unconsciousness lasting less than 24 hours, and there's also history of hemiparesis 13 years back. Patient is a known case of diabetes mellitus and hypertension on treatment, and there is no significant family, personal, or allergic history. The general physical examination and systemic examinations were within normal limit with slightly elevated blood pressure. The right eye examinations were within normal limit, and in the left eye, the vision in the where was perception of light present and projection of rays were inaccurate in all the directions. There was circumciliary congestion in the left eye, and the cornea was hazy due to diffuse microcystic edema. The anterior chamber was shallow with grade 1 hyphema, and the rest of the details of iris, pupil, lens, and fundus were hazy due to corneal edema. The fundus globe was absent in left eye, and intraocular pressure in left eye was raised to 66 millimeters of mercury. So the patient was managed in the emergency with IV mannitol 300 ml over 30 minutes, and the IOP reduced to 32 millimeters of mercury. Post IV mannitol, the corneal edema and haziness decreased in the left eye, and anterior chamber was visible with the cells of 4 plus and flare 2 plus, and the VH grading of 2. There was 360-degree iris neovascularization, and there was loss of normal pattern of iris, and the pupil was mid-dilated, not reacting to light. And there was presence of posterior chamber intraocular lens, suggestive of past cataract surgery. On gonioscopy, in the right eye, the angles were open. However, in left eye, there was presence of neovascularization of angle in all the quadrants, and the view was hazy to obscure any to show any other features. On the fundus examination in the left eye, the media was hazy. The disc showed complete pallor. There was pale and edematous retina, and the retinal veins were narrow. Retinal arteries were attenuated. FR was absent, and there was old patchy pigmentation in the mid periphery. And the fundus examination of right eye was within normal limits. This is the fundus photograph of the right and the left eye, where the left eye shows complete pallor of the disc. There was attenuation of retinal arteries and narrowing of retinal veins, and there is a peripheral old patchy pigmentation seen. And the patient was managed with topical eye drops in the left eye, which were eye drop prednisolone 1%, humide 2%, and eye drop brimonidine and timolol. Patient was advised certain investigation like CBC and ASR, which were within normal limit, and the blood sugar levels of the patient were raised. On the fundus fluorescent angiography was done in both the eyes in the arterial early venous and mid venous phases, with the right eye showing capillary non-perfusion areas in the mid periphery, staining and late leakage from vessels due to ischemia, which is seen here, and the microaneurysms in the mid periphery. The left eye showed arm to retina time, which was delayed more than 40 seconds, and there was no filling at all in arteries or veins. And also in the right eye, the macular thickness was within normal limit with normal foveal contour. However, in the left eye, there was thinning of macula and there was loss of foveal contour. Here is the CT MRI of the brain with the T1 and T2 images showing the hypointense and the hyperintense lesions in the frontal, parietal, centrum, semioval, and the
So your
occipital
4
regions
minutes
of
are
the right.
up. Please wrap up fast.
And bilateral carotid artery Doppler showed atherosclerotic plaque, and the cerebral DHA showed high-risk stenosis, more than 98% in bilateral internal carotid artery with multiple telangiectatic vessels, which are seen here beyond internal carotid artery, characteristic of puff of spook appearance of Moyamoya disease. So my probable diagnosis is right eye capillary non-perfusion areas in the periphery, and the left eye neovascular glaucoma and ocular ischemic syndrome secondary to Moyamoya disease. The patient was managed with right eye panretinal photocoagulation, and in the left eye, poor visual prognosis was explained, and topical IOP lowering drugs were prescribed. Antidiabetic, antihypertensive medications were continued, and cardiac and neurology consultation was taken for the same. Thank you.
Thank you, Dr. Barkha. And now I invite the judges to please go ahead with the questions.
Thank you.
Dr. Barkha, why it is not a case of simple diabetic retinopathy, right eye and left eye leading to neovascular glaucoma? Why you have gone for neurological investigation?
It's not just a posterior segment finding, there are also anterior segment finding concurrently, and also there is asymmetrical involvement of both the eyes in the posterior segment. Had it been diabetic retinopathy, the involvement of the posterior segment had not been this variant in both the eyes. Also, there was neovascularization only in one eye, not in the other eye, which is not seen in that evident in diabetic
It happens,
retinopathy.
it happens, it happens. Which sign you have thought of going for a neurological investigation? Why?
Ma'am, there was a patient gives the history of cataract surgery, post which the vision did not
I'm just
improve in the
asking
left eye.
any systemic symptoms you have seen in the patient when you are saying Moyamoya disease?
Ma'am, the
There are some
patient says that
symptoms.
she had she had the history of hemiparesis. There were multiple episodes of transient loss of vision in the past. And she also says that there were multiple episodes of unconsciousness also in the past,
That's what
which
I'm
were
asking.
transient, lasted less than 24 hours.
Anything else?
Ma'am, she also complains of headaches, which are mostly she did not had all these episodes of headache earlier. Also, she told that she started getting these while there was episodes of blurring of vision. At the same time, she had headache also. So these all correlate with the finding, because there are infarction of the dural arteries, which leads to headache in these cases.
Okay. 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 Thank you.
Any similar case you found in the family because it's having a genetic predisposition to reduce
No,
screen?
ma'am. The family, usually there is a family history in Moyamoya disease. However, in this patient, there was no family history as such, ma'am.
Okay, so what is the ultimate prognosis of this Moyamoya disease? Do you know what happens? There are certain stages of that. Yeah, Barkha, you are here. I think there is some problem in the network. Hello?
Dr. Barkha, are you there?
Ma'am, am I audible?
Yeah,
You're
now
audible.
you're audible, Barkha. I wanted to know that
Ma'am,
what
ma'am,
happens when you know about this disease? What happens to the patient ultimately?
moyamoya disease, usually it is more common in children around 4 years of age, and however, it is also seen in 50s to 60, 80s years of in the 50s and 80 years of age, and when the moyamoya disease occurs in children, it is usually of ischemic nature. However, when it occurs in adults, it is usually of hemorrhagic nature. Whatever be the ischemic or hemorrhagic nature, it always leads to brain damage and atrophy of the cerebrum. Also, in this patient, there was atrophy noted, and this leads to behavioral changes in the patient as well as the decreased cognitive decline, decreased cognition. Also, because these patients are at increased risk of mortality because of cardiac involvement. In my case also, the patient is is a high risk case as she is diabetic, hypertensive, and dyslipidemic, and therefore to decrease her mortality, she was advised aspirin, clopidogrel, and atorvastatin.
Okay, thank you.
Thank you, ma'am.
Swati ma'am, please unmute yourself. You're not audible because of that.
Can you hear me?
Yes, ma'am, you're audible. So, yeah.
Okay. What is the etiology for this?
Ma'am, the etiology of moyamoya disease is genetic.
Okay, genetic.
Yes, ma'am.
Okay.
The gene is involved is RNF123, ma'am.
Okay, I think that's
It
it
is
for
usually
Dr. Barkha. Thank you so much for your presentation and the good discussion. And this brings us to the end of the first
Thank you,
competitive
ma'am.
session. And I think it was a great session with a good potpourri of cases, for which I thank all the participants, the mentors and mentees, for taking the pains of preparation and their hard work. And I would also like to thank the judges for their minutest of observations, their involvement. Thank you so much, everybody. And I hand the mic back to Dr. Minakshi to continue the program. Thank you.
Thank you, Dr. Amrita, and for conducting the first competitive session, and congratulations to all the participants and their mentors for their hard work, and thanks to the judges also. So now we are moving to our next faculty talk, and I would like to invite and welcome Dr. Jimmy Mittal ma'am to enlighten us on Project Shakti. Over to you, Madam Mittal.
Good morning, everyone. Am I audible?
Yeah, ma'am, you're audible.
Good morning, everyone. Am I audible?
Yes, ma'am, you're audible.
Am I audible?
Yeah, ma'am, you're audible.
Good morning, everyone. Are you able to hear me, all of you?
Yeah, ma'am, we can
Yes, yes.
hear you.
So am I audible to all of you?
Yes, ma'am. Yes, ma'am.
Yes, ma'am, you're audible.
Am I audible?
Yes, ma'am, you're audible.
Hello?
Yes,
Yes,
ma'am,
ma'am.
you're audible.
Am I audible to all of you? Hello?
Yes, ma'am. Yes, ma'am, it's clear. Ma'am, you're audible?
Hello? Okay, ma'am, I can't hear anyone, so I was not able to understand. Okay, ma'am. Okay, sorry for the interruption. I'll just share. So good morning, everyone. At the outset, I would like to thank Dr. Mohita Sharma ma'am, Dr. Madhu ma'am, and Dr. Masi for giving me this opportunity. So I'm here to talk about a very important ongoing project of WOS, which is Project Shakti. So we'll here talk about how to identify the workplace harassment challenges and how to go about managing them. So yes, workplace harassment actually exists. It exists throughout all types of workplaces. It can happen from simple bullying to outright discrimination. It's important to understand workplace harassment so that you can avoid a hostile work environment and have a peaceful working place. So how does harassment actually affect an individual? They not only affect an employee's productivity at work, her comfort level and safety at work, but has long-term effects also in the form of physical and psychological effects, mental harassment, health effects, and financial effects. A point important to note is it can also expose an organization to legal liability if the organization does not handle the harassment case or complaint presented to the organization properly. What are the types of harassment? While the most basic types of harassment are verbal, psychological, or emotional trauma, there are also some serious forms such as physical and sexual harassment. So all types of workplace harassment are illegal in nature and they should be reported ASAP. This is a chart showing different types of workplace harassment. We have psychological harassment, sexual harassment, third-party harassment, discriminatory harassment, personal level harassment, physical harassment, power harassment, and cyberbullying also comes in the workplace harassment scenario. So what constitutes workplace harassment? According to the Equal Employment Opportunity Commission, harassment can include offensive jokes, slurs, or epithets made at you at your workplace, your name calling, physical assaults or threats, intimidation, ridicule or mockery, insults or put downs by your superiors or your colleagues, offensive objects or pictures shown to you at your workplace, which is actually interfering with your work performance. So why reporting workplace harassment is important? Now, it is important to report any form of workplace challenge or harassment which you are facing because there might be others who have already reported similar offenses by the same person. He may be a repeated offender. So just making a mere complaint, you can already re-emphasize the complaint made previously. Many organizations have formal policies for reporting workplace harassment. So make sure when you're joining an institution, check your employee handbook if you are committed to reporting and know how to go about in such a condition when your HR is available. So it's time to speak up. Garvin, who's a social activist, has rightly said, if you know someone who is being harassed at your workplace, you cannot lose your job by reporting it yourself. So not only you will speak up for yourself, but also for your colleagues. Remember, you are not only protected by law from the person who is harassing you at your workplace, but you are also protected from your employer failing to protect you. It's a moral duty of the employer to protect his employees at workplace. So what should you do when you feel harassed? Workplace harassment is a serious issue with a lot of gray areas, so you should tread very carefully. So if you witness a crime or experience harassment at your workplace, it is your moral obligation to report it. If you're worried about losing your job in retaliation, remember that you're always protected by workplace harassment laws, which are applicable in all the countries. So yes, proactive steps should be taken to identify and prevent workplace harassment. For example, companies or institutions or hospitals can have a person of contact who is easily approachable and understands the psycho-emotional condition of the patient who's making the complaint, person who's making the complaint, so that victims and witnesses can report the harassment situations in a very easy and anonymous way. How to report workplace harassment? First of all, you need to decide to speak up for yourself. You can discuss the issue with your family members, your friends, your mentors at work, your professional seniors. And if the matter is a grave matter, you can also approach a lawyer or a psychologist. Now, you have to be very firm and specific with your approach. So remember, if you are the employer and an employee comes up to you and says about something about unprofessional conduct or inappropriate behavior, you can ask the employee to describe the conduct more specifically with details. So keep detailed records of each indiscretion which has happened. Example, the people who were involved, what was actually said or done to you, where and when the abuse had occurred. So document each incident in detail to bring it on record later on. The date, the time, and the place of the incident should be noted, preferably through emails and written applications. Now, why? Because written applications definitely have an upper edge and hold much importance in the court of law. in comparison to oral or verbal communication. Share your problem with the authorities, your HR, and the Vishakha committee. Now, Vishakha committee it's a very important and a very important committee which every hospital should be having against sexual harassment cases. And now you have WOS for all of you. We are working for you. Evaluate your workplace policies at least once in a year to ensure they are up to date if such a case arises. This was a brief what to do. And now I'll tell you what not to do when you face a workplace challenge, because these mistakes can actually escalate the situation. So first of all, do not retaliate. Do not get angry. Do not start, talking back to the senior or your colleague. Retaliation can escalate the issue and will often make matters more complicated. So instead, escalate the issue properly through the proper channel. Let your HR professionals handle things from there on. Do not complain to your co-workers or co-colleagues because, first of all, your colleagues do not have much power to change anything in this present scenario. They're sailing in the same boat and will likely to water down your version of events if they're asked to testify and become a witness for your problem. Last but not the least, the most important one, do not keep quiet and think you're alone. You should always report any form of harassment or challenge which you are facing. And believe me, it is handled well if it goes to the proper channel. So we have Project Shakti, which is an ongoing WOS project for all of you. It has a committee of expert panelists. The panel of senior female ophthalmologists and male ophthalmologists is there, along with a lawyer, a human rights activist, a member of the National Women Commission, and a psychologist on board. So what does actually, when a complaint comes to us, what do we do? The role of WOS is very significant because we at WOS take every complaint seriously, try to investigate every complaint in an unbiased fashion, and share and discuss the situation with our expert panel. We maintain the confidentiality, sensitivity, and anonymity of the person who is making the complaint to us. And we try not to make any credibility judgments based on the reputation of the person who's complaining or of the person who is being accused of harassment. We'll assume that the person making the complaint is not being oversensitive, because one person can find it very normal, but the other person can be sensitive or emotional and can find that situation very morally disabling. We'll not leave it to both the parties to work it out alone. We'll actually intervene. So once the complaint has been verified by our panel and found to be genuine, we'll take up the issue maybe through a mail with the concerned hospital institutional authority requesting for a formal inquiry and required action to be taken against the harasser. We'll also decide if any psychological, legal, or professional help is required in this matter. And if yes, the person is actually going through a very traumatic experience, we can help the person connect with a psychologist or a lawyer if required. So WOS encourages a zero tolerance harassment policy at every workplace. Now, anti-harassment policy is required and it is very, very necessary to have it because it will be a deterrent to future such issues at your workplace. It will outline the methods of use when such a situation arises. It will raise awareness of your intolerance towards such situations, prevents legal liability, and also strengthens your complaint if you have a policy in place. So it's always better to have an outline at your workplace when you're working. So remember, all of us deserve a very safe workplace. And please feel free to report any kind of workplace challenge or harassment at iwosindia@gmail.com. We at WOS are here for you, and together we can make a difference. Thank you for your patient hearing. So I shall be sharing the Google form which we have created at Project Shakti to just a survey form to get your feedback regarding your experiences. And I'd like everyone to please fill the form. Thank you so much.
Thanks a lot, Dr. Jimmy Mittal, for briefing us about Project Shakti. Now I would like to invite Dr. Colonel Madhu Bhaduria ma'am, who is the president of Women Ophthalmic Society, and she has received the Vision 2020 Women Lead in Eye Care Award in 2024. We congratulate ma'am for this. And now I would invite Dr. Madhu Bhaduria ma'am to motivate us and speak on what not to do to get motivated. Dr. Madhu ma'am.
Good morning. So I am not going to be showing any slides. I would be working from the, can we have that view in which we can have the speaker view so that all of you can sort of, I want to communicate in a proper way so that you all can really understand. So first and foremost is my very, very dear friends, juniors and residents. I can feel that the maximum population that is here is of students and teachers, right? And with the kind of going examination system and the kind of going changes in NMC, exams, everybody seems to be truly demotivated. Yesterday, I was coming in a lift and I heard two boys, how to go through NEET, what to study. So everything seems to be changing. And the changing times are very turbulent. And those are the times when we feel really demotivated. So my talk is actually what to do so you don't get demotivated. That means things will happen around you, but it's you who can help yourself more than anything else. Surroundings and things we cannot change, but we can change ourselves. So just look back into our kind of lives. What are the things that truly demotivate us? First and foremost, what I've been gathering from the residents and everybody, there seems to be a lack of trust in leadership. Residents no longer really believe in the examination systems. Somehow very unfortunate, but their trust in the teachers is also becoming very limited. What I'm telling you is a first-hand information because I'm a teacher myself. So they also feel that teachers are not, they don't know well enough. That is not actually true. The pattern has to change now, that whatever knowledge is required, which was a standard function earlier, was to deliver knowledge to students, has changed now. That knowledge is available on ChatGPT, knowledge is available on Google, on Wikipedia, iWiki, everywhere knowledge is available. So students from teachers are no longer actually looking for knowledge. Then what are they looking for? They're looking for being mentored and guided as to how to acquire knowledge. So for teachers, I would say that the motivators would be different than they will be for students. So let's first go to our teachers only. Teachers are really good. They're very knowledgeable. But what is happening here is a major communication gap between the students and teachers. The trust is very minimal. So first and foremost is between students and teachers. To remain motivated, you've got to place your trust in each other. The students have to believe that the teachers are their parents. They have to respect them. They have to communicate with them, reach them, and ask for help whenever they need for anything other than the standard curriculum. Because if that does not really happen, if the communication is poor, then students keep thinking of something else, and फिर हवाओं का बाजार गर्म होता है. Then the students don't know something, teachers don't know something about them, and there are people always, that there'll be some students and some teachers who will always try to tell each other that I'm better than everybody else and I'm your well-wisher, others are not, which is not generally so. So the first thing probably to remain motivated is between teachers and the students is to keep the bridge intact. And the bridge is a bridge of communication, trust, and the bridge of doing well for each other, because students or teachers alone are nothing. An institution, which is a college, is totally a mixture of students, teachers, and administrative staff. And that is the third factor that comes in. So good communication is the key for remaining motivated, because once you understand, once you feel the trust, once you feel the strength of each other. Now the students, what's happening to them is they're fully confused. The students do not have a goal. Students by and large have to set their own goals. And goals are not just like that, like I will finish glaucoma in one day. Now this goal is a very qualitative goal. This goal cannot be achieved. It's not measurable. So I want to talk about a little bit of goal setting for kids, which is very important. It's important for everybody else also for the life, because it's not only studies about life. So what really happens in the goal setting is that you set a goal which is doable, and also it is measurable goal. Suppose in a day you decide that today I am going to learn pigmentary glaucoma. Now that has to be cut in pieces. This much portion, suppose I've seen a case of pigmentary glaucoma today. I've seen this clinically, this I will read in the book, and I will put the checklist matic that this is something that I've read. So like that, when they join the college, everybody must make goals. These are my subjects. These I have to study. This is where I have to reach clinically. This is the way I have to reach my skill. This is the way I have to reach my knowledge. And this is the way I have to reach my presentations. This is the way I have to reach my research. So set those things, make your checklist, make your areas. And then when you achieve your goal, whatever small goal it may be, celebrate that little goal of yours. It's not a big deal. I used to always wonder as a student, as to when somebody is doing a surgery, why the hell they're giving samosas to everybody else? It's not a big deal. But when you realize that something that you've done for the first time and you have sailed through it, it's such a pleasure to sort of give that treat and to receive that treat. So goal setting is one thing for students and even for teachers also. Actually, they have to help them in setting their goals. And teachers need to set different kinds of goals for themselves. Something like, this is what I'll teach today. This is going to be my family goal, my personal goal. This is the amount of rest I will take. These are going to be my hobbies. So this much time I'll give for my hobbies, because all these things put together make our lives. Our lives is not only studying. A life is not only watching, looking at the phone all the time, even when you're in conferences. I see so many people, they're in the conferences, their bodies are there, but their minds are, God only knows where they are. Like I find students actually in the middle of the class looking at the answer. You ask a question, they will look at the phone and they will read from there and answer. So these are not the good things to happen for anybody at any time of the thing. So concentration and focus have to be brought in. That is another goal, how to work on concentration and focus. And or for concentration and focus, the best things, believe me, are yoga, meditation. Other than that, having a good productive hobby. You can sing, you can dance, you can read, you can this thing, something that is not a professional. I would not say you watch television, because television engages more than multiple faculties of yours and you're distracted. And so is the screen phone. Maybe limiting screen time would really help, other than for the purpose of education. There has to be a set time that I'll watch. I'm not saying don't watch TV for half an hour, 1 hour in a day. It's perfectly fine. We all are humans. We all do that. Then we really come down to what are the other things that demotivate us. We are developing very little tolerance for other people and colleagues. We have to have a certain amount of tolerance and try to understand. A lot of bullying and harassment is coming out of not understanding. Even I'm seeing amongst the seniors, what Jimmy said is a very right thing, that bullying is not only sexual harassment. Third years are bullying, second years are bullying. First years, you will do this, you will do that. You give a case to one person, the person will say, second year will work up and bring it back. Why not you? When consultants are seeing cases, what is wrong for third years working up cases? So that bit is that nurturing culture has to come. If you don't want to be demotivated yourself, you have to learn to help other people. When you help, when you nurture the people who are junior to you, who are lesser than you will be a much happier person, because you know what? Many times we feel our problem is huge. But when it comes to actually Mother Earth, when you listen to 4 more people, you realize, yeah, your problem was nothing much really. Other people have much worse problems. Because each one of you is unique. Your journey is unique. You're born unique. Your talent is unique. No two humans are same. Even the half of one side of face of yours to the other half of the face of yours is not same. So learn to appreciate yourself, treat yourself, learn to respect others, help others. Sometimes walk to community department, see the camp patients. They come in winters wearing just one sheer dhoti, or a man will be wearing just one sheer cloth. Maybe in Chhattisgarh it's not so cold, but up north these things are there. They are half fed. The first thing they want to do is to eat food rather than showing their eyes. So those underprivileged people, when you see them, your problems become much smaller. You can handle them a lot more easily. And then the worst of all is that we are forever comparing ourselves. Don't compare yourself. There's no one like you. You are the best. But you are the best, not God has not made you best and sent like that. God has given you capability to make yourself best. So work on it. Work on your skills. Work on your knowledge. Work on your personality. No matter how good you are, I've seen so many people, they're such skilled surgeons, good surgeons. Put them on the mic, they can't open their mouth. So the personality development is another important part. And in that, you have to learn to present yourself, how to talk to other people, how to treat other people, how to help other people, how to understand them. We all look at the human behavior. The human behavior is what? It's a tip of an iceberg. All the behavior that is yours on surface is just 5-10% of your forebrain or front brain knowledge. A huge amount of you is underneath. That's called an iceberg. What is inside that? Inside that are your past experiences. Inside that is your belief system. Simple example is cheating in the exam. for one student would be a normal thing because the belief system of that student says that it's all right. So whatever I've copied one question from somebody or I've asked the answer. Similarly, the other person's belief system must be, look, this is really wrong. It should not be done. So now they will be loggerheads, right? So therefore, your behaviors are not what is on surface. They're governed by what is your belief system. So I would request everybody to put some time, think, go back deep inside you as to how different things affect you, and you will know exactly what is inside you. So open your iceberg, see yourself, and whatever is modifiable, try and modify. So if you go for all these things like good communication, set the goals of your life, when you complete the goal, checklist, when you are checklisting and you're doing something good, the day you do a good cataract surgery, give a treat, and don't be afraid of mistakes. Never fear anything in life because mistakes only those surgeons don't make who don't operate. If you don't operate, you will not make a mistake. If you will operate, you will make a mistake. Now, best way to deal with it is only that accept your mistake, ask somebody senior, go back yourself. With the senior, when you go back yourself, your mistake will be it will be uncovered for you. And how to handle it will also be taught to you. Or you can discover for yourself also. It's not always that you need a teacher. Take recorded video home. Go back and check as to what mistake you have seen, or you're given the exam. Take back your copy and see what you've written is not right. And then ask. And the worst way to deal with the mistake is only one, and that is when you hide your mistake. You've dropped a bit of cortical matter or a part of the nucleus in the vitreous. Eye beautiful in front, everything. Patient comes back after 2-3 weeks, comes back with high IOP, comes back with inflammation. And then, like you will be caught, you will be punished, everything like that. So therefore, once you set your goals right, you work on them, develop on yourself, treat yourself well, treat others well. And don't be afraid of your mistakes, correct them. Believe me, there's nothing to demotivate you. You will be the most motivated person, and motivated people are 69% more happy than other people. They're 50% more productive than other people. They're 40% eat better, healthier things they eat, and they live a better life. So with this, I would call it an end. And I'm really happy to be here and to be with so many of you. I think the 30-40 participants here. So if I've reached out of 30-40 events, like if I've reached the hearts of you, say 10 of them, my day is made. I'm done. Thank you so much.
Thanks a lot, Madhu ma'am, for enlightening us and motivating us. And we always feel happy to hear you. So thank you so much, ma'am. Now we come to our competitive session 2, and I would like to invite Dr. Vijita Dev from ABI Super Specialty Eye Hospital to moderate the session, and I would request the judges to gear up. Okay, over to you, Dr. Vijita Dev.
Thank you so much, Dr. Meenakshi ma'am. And it's a wonderful day to learn and teach. So with this, let's just start our next session. I just have some requests to make. I request the speakers to stick to their time and also to introduce themselves well and their topics well. I also request the other speakers and the audience to keep their mics on mute so that we do not have any interference. So with this, we start. We move on to the next speaker, who is from Pandit JLNM Medical College. The first speaker of this session is Dr. Seema Ahuja, mentored by Dr. Swati Jain. So I request Dr. Seema to start, and please stick to your time. Thank you.
Good morning, ma'am. I am presenting a case of 44-year-old male who presented with sudden painless diminution of vision in left eye since 6 months. Patient was treated with steroids and visual acuity documented at that time was counting a 3 meter. His wife had history of intestinal tuberculosis in 2005 and no other significant clinical or clinical or systemic history was present. General and systemic examination were normal. On first visit, patient presented with right eye 6/6 vision, left eye vision 660 with near vision N36. Red-green color deficiency was present and REPD grade 1 was present in left eye, and fundus showed paleness with hypopigmented patch at macular area. On OCT, left eye showed RP distortion involving photoreceptor layer at macular region. On second visit, patient presented with sudden painless diminution on vision in right eye since 3 days. Right eye vision was 612 with near vision N8. Red-green color deficiency was present with diffuse visual field defect and grade 3 edema was present on fundus. Left eye findings were same. On right eye perimetry, generalized visual field constriction was present. On investigations, patient presented with Montauk's positive and MRI brain plus orbit showed intraorbital and intracranial segment of left optic nerve, which was suggestive of left optic neuritis. Patient was started on pulse IV methylpred and neurology opinion was done for the same, and they advised the patient for plasmapheresis, but the patient was not compliant to it. On third visit, patient presented with right eye deterioration of vision from 612 to 636, near vision N8 to N36, and fundus showed pale disc. Left eye findings were same. There was RNFL thinning in right eye at superior quadrant and infratemporal quadrant, and in left eye it was present globally. MRI orbit showed bilateral longitudinally extensive involvement of acute optic neuritis, and MRI brain showed lesion in left corona radiata and periependymal region, and it was suggestive of infective etiology, that is tuberculoma. But on investigations, CSF examinations came out to be normal, and including Mycobacterium TB was negative. NMO and MOG antibodies were negative, with MRI whole spine showed no significant abnormality. Patient was IgG positive for rubella, CMV, HSV 1 and 2. On FFA patient, there was RI. Sorry, there was in right eye there was RP modeling present in ferrotemporal disc and macula, and left eye showed hypofluorescent patch and also RP modeling at macular area. So our final diagnosis is atypical optic neuritis due to post-viral seronegative neuromyelitis optica, and alternative diagnosis is chronic relapsing inflammatory optic neuritis. So the patient was started on tablet prednisolone 60 milligram OD and acyclovir, and also the patient was started on tablet escitalopram and clonazepam from the neurology side as patient complained of insomnia. On fourth visit, patient presented with central serous neurosensory detachment in both eyes. So we started tapering steroids, and also acyclovir was tapered, and patient was started on tablet azathioprine 50 milligram BD, and rest treatment was continued same. It is important to note different MRI lesions of multiple sclerosis, NMO and MOG. As in our case, there was bilateral longitudinally extensive involvement of bilateral optic nerve, and there were relapsing attacks which were moderate to severe in nature, and usually these attacks are steroid resistant, and there was a periependymal lesion present in MRI brain. This is the image difference showing different lesions in MS, NMO, and MOG. Take home message: all patients presenting with atypical optic neuritis must be referred for neurology opinion, and MRI brain and orbit should be done along with testing for antibodies.
Thank you, Dr.
Patient
Seema. Your time is up.
Thank you, ma'am.
Please conclude.
Ma'am, so our final diagnosis is neuromyelitis optica for patient for which patient was treated with steroids, and then immunosuppressants were started to prevent relapsing attacks. Thank you, ma'am.
Dr. Seema,
Yes, ma'am.
your patient didn't improve with the IV methylprednisolone in the first line of treatment. First, you started, or you started with the oral prednisolone first.
Ma'am,
I think you started with the oral.
Ma'am, we gave the patient IV methylpred, but there was no significant improvement in vision. So
Even
we
it I think.
yes, ma'am, with methylpred also. So we have suggested for neurology opinion,
and they suggested the patient for plasmapheresis, but patient never went for it.
What was the first visual acuity when the patient reported you?
Ma'am, in left eye it was 660, but in my second visit, patient came with right eye optic neuritis, and the vision deteriorated to 612. But patient never went for plasmapheresis, so it further deteriorated on third visit.
That means your patient didn't respond to steroid. Okay?
Yes, ma'am.
You want to tell that, no?
Yes, ma'am.
Patient responded to oral steroids, no? Or did not?
Ma'am, we started oral steroids, but they were started after the acute attack has subsided. So it was just started for preventing relapsing attacks, but the patient developed CSR, central serous neurosensory detachment, and also complained of insomnia. So we started immunosuppressants, but
Why was acyclovir given here?
as patient was IgG positive for rubella, CMV, and HSV 1 and 2, and studies show that there, in some cases, there are viral illness associated with starting of NMO attacks.
Okay. What is ONTT trial? Optic neuritis treatment trial, basic question.
Ma'am, it says that if patient presents with optic neuritis, we should start IV methylpred for 3 days, 1 gram, and then 11 days we should give oral prednisolone 1 milligram per kg, and then we should taper the oral steroids in every 3 days.
Okay. So what you're planning for this patient now?
Ma'am, the patient is currently under monitoring. If in future it develops further NMO attacks, and if it becomes NMO antibody positive or attacks the spinal cord, mainly cervicodorsal area, and if there is longitudinally extensive involvement of spinal cord, it may be diagnosed as NMO. But if there are no antibodies positive in future also, and there is no involvement of spinal cord in future, then we would diagnose it as chronic inflammatory optic neuritis, relapsing inflammatory.
Okay, thank you.
Thank you, ma'am.
Thank you, judges. If there is, ma'am, Swati madam, do you want to ask any questions?
Actually, I have not heard her, so please let me excuse for
Okay,
that.
ma'am, no issues. So, so we'll move on to the next speaker. The next speaker is Dr. Nikita Behra and mentored by Dr. Monica Singh. She is also from Pandit JLNM Medical College, Raipur. So moving on to Dr. Nikita. Dr. Nikita.
A very good morning to all. Myself, Dr. Nikita Behra, second year resident. So starting with
There
the
is a lot of echo, Dr. Nikita.
Starting with the case, a 40 years old male hailing from Rajendra Nagar, Raipur, came with a chief complaint of diminution of vision in both the eyes for 2 months, which was insidious in onset, progressive and painless in nature. He's a known case of diabetes mellitus for 5 months, a known case of HIV infection for diagnosed 5 months back, for which he is under treatment. No significant family history. General physical examination was within normal limit. Mouth heat and alopecia was seen. Systemic examination was within normal limits. Local examination was normal. Moving on to ocular examination, in right eye distance vision was a counting finger 3 meter with BCVA counting finger 5 meter, and in left eye distant vision was counting finger 6 by 60 with a best corrected visual acuity of 6 by 9. Moving on to anterior segment finding of right eye, conjunctival and circumciliary congestion was present, diffuse fine keratic precipitates, flare of grade 1 plus, broad base posterior synechia at 6 o'clock, iris pigments over anterior lens capsule was there, and intraocular pressure was 18 millimeter of mercury. Coming to anterior segment examination of left eye, diffuse fine keratic precipitates were there with a flare of 1 plus, IOP was normal. Coming to the fundus examination of right eye, showing media clarity of grade 2, hyperemic disc with ill-defined margins, and AV ratio was a 2:5 with round yellowish placoid lesions, 1 disc diameter superior temporal to disc and 1.5 disc diameter superior nasal to disc, suggestive of chorioretinitis lesions, and few flame-shaped hemorrhages in the superior temporal quadrant was there, with some fine lacy fronts of multiple irregular vessels arising from center of disc were there. Fundus examination of left eye, media clarity was grade 0, hyperemic disc with ill-defined margins, rest was within normal limit. So my differential diagnosis are CMV retinitis, syphilitic panuveitis, acute retinal necrosis, progressive outer retinal necrosis, tubercular panuveitis. The routine investigation were within normal limits. RPR was reactive, TPHA was positive, HIV was positive, MRI brain plus orbit suggestive of bilateral optic neuritis. This is the B scan of right eye, showing scattered hyperechogenicity suggestive of vitritis. This is the OCT of right eye, showing thickened hyperreflective retinal pigment epithelium. And this is the late phase of fluorescein angiography, revealed presence of peripapillary hyperfluorescence due to leakage suggestive of NVD, and pinpoint leakages in the along the peripheral retinal vascular arcade in the right eye. So my final diagnosis is OD syphilitic optic neuritis with panuveitis with chorioretinitis, with immature senile cataract in OS and OS syphilitic optic neuritis with anterior uveitis with immature senile cataract. Management: injection benzathine penicillin G 2.4 million units intramuscularly once weekly for 3 consecutive weeks. Antiretroviral therapy: hydroprednisolone 1% 6 times a day for both eyes, and hydropitropin 1% 3 times a day for right eye. 1 week after third dose of injection benzathine penicillin G, vision in right eye was improved to 6, BCVA was improved to 6 by 6 from counting finger 5 meter. On slit lamp examination, broad-base posterior synechia present at 6 o'clock, and iris pigments over lens were there, but KPs were resolved, and in left eye also KPs were resolved. This is the fundus examination after treatment, which shows a improvement in media clarity, and we can clearly see that there is significant reduce in the size of both the lesions. So to conclude, ocular syphilis represents a great significant diagnostic challenge, as it is a great masquerader in uveitis. For this reason, along with detailed medical history of the patient, multimodal imaging could provide the appropriate tools to handle with the multifaceted clinical features of the disease. Thank you.
Thank you, Dr. Nikita. You were well on time. So moving on to the judges.
What to tell about what is the take-home message, Nikita? You're saying?
Ma'am, because the syphilis is a great masquerader, it can mimic the other. It can mimic other causes of uveitis, so it is very important to do detailed medical history, multimodal imaging, and appropriate tools to handle this multifaceted clinical presentation.
Means your patient was immunocompromised, HIV positive. Why not?
Yes.
It is a CMV, simple CMV retinitis or panuveitis. Most common.
Because it VDRL and TPHA was came out to be positive, and CD4, ma'am, for CMV retinitis, CD4 count usually should be less than 50, ma'am, but in this patient, CD4 count was 530.
Any clinical difference you have seen in your patient? In the clinical finding, anterior segment, posterior segment?
Ma'am, in CMV retinitis, there is a...
You have seen in your patient, I'm talking, not theory I'm asking.
Ma'am, they were fine granular KPs present in my patient, fine KPs.
Your experience, I'm asking, you have seen anything difference in the syphilis or CMV retinitis or anything else, any compromised patient you used to see?
Ma'am,
Just for the knowledge, I'm asking for others also. If you see without if you are not having all this investigation modalities, multifaceted,
yes, ma'am.
clinically
Ma'am, in CMV, yes, ma'am, in CMV retinitis, pizza pie appearance or brush fire appearance can be seen on fundus. And ma'am, in syphilis, ma'am, usually chorioretinitic lesions were ma'am multifocal and yellowish lesion. And ma'am, in syphilis, it typically primarily involve posterior pole, then it spreads to periphery. While in retinal necrosis, it starts from periphery and then it involves a posterior pole.
Tubercular uveitis, difference between tubercular and syphilis?
Ma'am, in tubercular uveitis, ma'am, there were granulomatous KPs present, ma'am. Large mutton fat KPs were there, ma'am, in tubercular uveitis.
Okay, thank you.
Thank you.
Yeah, what is this moth-eaten alopecia that you mentioned, Dr. Nikita, and in which cases this is found? This is maybe a little out of ophthalmology, but that phrase attracted my attention. So moth-eaten alopecia.
Ma'am, it is a pathognomonic feature of secondary syphilis, ma'am. Most commonly seen in secondary syphilis, ma'am. It is a non-scarring.
How do you describe it? What is moth-eaten alopecia?
Ma'am, it is a non-scarring alopecia, ma'am, and considerably it affect ma'am hair bearing area, ma'am.
Yeah. This is also found in, I think, tinea infection or those, psycho patients who take off their hairs on their own and
yes, ma'am.
Pixelomania or something.
Yes, some tinea capitalis.
Okay, fine. Yeah. What is happening is that most of the presenters, they are not able to switch on the video because of low network or something. So we are not able to judge whether they are reading and telling us the answers or, just on their own, they are doing it. Okay, so this is a complicated situation. The patient is having HIV. There can be other DDs also, as you mentioned. So what are the other DDs you mentioned for this? Before investigations, what are the other DDs you thought of with uveitis? One is CMV.
CMV retinitis, ma'am, progressive outer retinal necrosis. Tubercular panuveitis can be there, ma'am.
Okay, right. Soumya madam already covered all that. Okay, thank you, Nikita.
Thank you.
Swati ma'am, you're not audible.
Can you, what are the other causes for chorioretinitis? Can you hear me?
Yes, ma'am.
Yes, ma'am.
What are the causes for the chorioretinitis, other causes?
Ma'am, toxoplasmosis, tubercular chorioretinitis, syphilis, syphilitic chorioretinitis, acute posterior placoid chorioretinopathy.
Okay.
And other viral causes can be there.
Okay. So moving on to the next speaker, Dr. Tushani
Brijita,
Kashyap.
can I?
Yes, ma'am. Yes,
Brijita,
ma'am.
just sorry
Yes,
to
sure.
interrupt. Can I
No, no.
kindly request the presenters, if possible, to
Yes,
switch
ma'am.
on the video during their discussion session?
Yes.
Yeah,
We'll do
thank
that.
you.
Thank you. So, Dr. Tushani, are you there? Can you switch on the video as well? So, next speaker is Dr. Tushani Kashyap from Pandit JLNM Raipur. She is being mentored by Dr. Vinanti. Yes. Over to you, Dr. Tushani.
Yes, ma'am.
Are we ready, Dr. Tushani?
Yes, ma'am. Actually, ma'am, there's some problem in the connection. Just give us 1 minute.
Sure. Sure.
Ma'am, am I audible? Hello.
Yes, Dr. Tushani.
Ma'am, my screen is audible.
No,
Yes,
your
it's
screen is
visible.
not visible, but
Go to slideshow. Yeah, go here. Come here.
yes, your screen is also visible now.
Okay.
So we
Good
can
morning.
start.
Yes, ma'am. Good morning, consultant. We're going to present a case of proctologist. And where 21-year male president of Chhattisgarh is presented with
So there's an echo now in the voice.
Yes, there's lots of echo. I request the other attendees to please switch off your mic. You can start, Dr. Tushani.
There is swelling and redness and outward confusion and complete loss of nutrients in the left eye is the reason.
Hello. Hello.
Please, I request the others to please switch off your mic. Yes, Dr. Tushani, we can carry on.
Yes, ma'am.
21-year-old male resident of Chhattisgarh presented with a chief complaint of swelling, redness, and outward protrusion and complete loss of vision of the left eye.
These complaints were
Tushani, you're not audible now.
Hello.
Yes.
Hello.
Yes, you can go on.
Tushani, if there is a network problem, you can switch off your video now. I just wanted it on during the question answer session.
Yes, we can
Okay.
do that.
Yeah,
Yes, we
yeah.
can do that. Just switch on your audio, switch off your video for now.
Hello.
Yes.
21-year-old male presented with a chief complaint of the left eye since 3 years. Ma'am, am I audible?
You're audible, but there is a lot of disturbance in the line. Carry on, Dr. Tushani, carry on. Just be a little loud when you're presenting. Dr. Tushani, you there?
Yes, ma'am, she's connecting her slides.
Yes.
21-year-old male presented with the chief complaint of swelling, redness, outward protrusion, and complete loss of vision in left eye since 3 years following head injury due to road traffic accident. After this patient present with the sudden these complaints are sudden in onset, rapidly progressive, associated with the redness.
अपडेट पे लगाया अभी अपडेट एंड शटडाउन पे ठीक है
associated with the redness, swelling, mild pain behind the eyeball and headache, sometimes associated with the squeezing sound. There is no history of pain on ocular movement, increase in the size on the during the curve, and physical staining or change in the position. There is no history of vomiting and convulsion. Patient gave the history of head injury in the January 2020, for which he operated. He visited AIMS Raipur and diagnosed as the left eye traumatic optic neuritis, and conservative managed done by the neurology department and ophthalmology department. Patient visited us after the 3 years of trauma for the above mentioned complaint for the further management. Systemic history and the personal history is not significant. Family history, general physical examination, and systemic examination came to be normal. In the proptosis examination on inspection, there is unilateral non-axial proptosis of left eye, Nabzinger sign positive. There is no change in the size during the Valsalva curve or straining or bending. There is legophthalmos present. Periorbital skin is normal. On the Lutz exophthalmometer finding, there is right eye 19 mm, in the left eye 27 mm. We measured for the dystropia. Vertical dystropia is 4 mm and horizontal dystropia is 26 mm. On the palpation, orbital margin was intact and orbital walls are appreciated during the finger insinuation. On the auscultation, bruit was present. In the visual acuity of the right eye, it's 6.6, which is improving. BCVA is 6.6, and in the near vision is N6, and the color vision is normal. In the left eye, perception of the light is negative. In the right ocular examination, right eye examination is normal, and the left eye is forward downward lateral displacement, and the interpalpebral aperture height is 16 mm and width is 30 mm with dilated episcleral vessels. Chemosis present, grade 1, and RAPT grade 2, and the ocular movement is restricted in all direction. In the fundus, right eye fundus is normal. In the left eye fundus, media clear, disc pale, disc present, and AV ratio is 2:4. Macular area and peripheral area are normal. In the cranial nerve examination, we found that optic nerve, oculomotor nerve, and trochlear nerve and abducent nerve affected. My differential diagnosis is left eye carotico-cavernous fistula and left eye orbital roof fracture. We did the investigation. Blood investigation is within normal limit. We advise for the MRI brain flush or CT. In the series of this, CCT head and flower orbit was advised, which show bulging of the left eyeball with dilatation of the superior ophthalmic vein. MR angiogram revealed that there is left direct caroticavernous fistula with feeders from the left ophthalmic artery. My final diagnosis is left eye direct caroticavernous fistula type 1 as per the Barrow classification. Management was done with the collaboration of the radiology department. Patient had undergone transarterial balloon assisted coiling endovascular embolization. Embolization of the feeder is done with the liquid embolizing agent. Embolization, this was the picture after the embolization, and this was the post of photo of the patient after the 1 month. My take home message is proper history taking, clinical examination, and appropriate investigation and combined effort with the radiology department help us to diagnose and manage this case. Thank you.
Thank you, Dr. Tushani. With such a difficult, the net you have managed to present well. So now we would want the esteemed judges to ask any questions they want to ask Dr. Tushani.
Dr. Tushani,
Yes.
you are saying it was a gap of 4 years or 3 years after
3
trauma?
years, ma'am. Ma'am, after 3 years.
Just a minute, ma'am. I just want Dr. Tushani to switch on her video as requested by Dr. Lipi so that she can answer the questions.
Yes, ma'am.
Yes. Yes, ma'am.
Again, she is gone. The video.
My eyes.
Yeah, it's okay. It's okay.
So
It's okay if there's a network problem. There are hardly one more presentation left.
Okay.
If there's a network problem, it's okay. She can be off video.
Okay. Okay. Yes. So questions from the judges, please.
Dr. Tushani, you are saying it's a gap of 3 years.
Yes,
So he
ma'am.
was having his investigation done before?
No, ma'am. Patient was diagnosed orbital or optic neuritis 3 years back at the AIMS only. After that, patient doesn't visit anywhere.
No, because you're saying it was a, what was the sequelae of this keratoconus fistula?
Ma'am, patient had a trauma RTA 3 years back. After the 1 week, 1.5 week, patient had a history of sudden diminution of vision and the proptosis. After that, ma'am, patient was managed conservatively at that time of trauma only. After that, patient did not take any treatment from anywhere.
Okay, what do you think? What are the causes of keratoconus fistula? What was the mode of trauma? It was a trauma, roadside accident, which type, blunt trauma. See, you have mentioned here the cause also
Yes,
in your
ma'am.
investigation.
Head injury, ma'am.
Which type? Head injury will not lead to that keratoconus. Be specific.
Ma'am, following RTA, there are closed globe injury, ma'am.
No, every head injury can lead to keratoconus fistula.
No, ma'am.
Then, in your case, that's why I'm asking. Any investigation, neurological investigation, CT scan, MRI was there with the patient? X-ray, simple X-ray.
Yes, ma'am. But ma'am, X-ray was done, ma'am. But there is no history of any orbital wall fractures, ma'am. That.
Just a request to all of you, if you are mentioning a case which has taken treatment in other institute beforehand, so don't mention the institute, just other place or other institute. I think it's a rule of any presentation, please.
Absolutely, ma'am.
Yeah. Okay. Thank you.
Any
Yeah,
other
Tusharni.
questions? Yes.
Yeah, I would like to know what are the signs you told of this CCF which you found ophthalmologically? What are the ophthalmologic signs?
Yes, ma'am. Ma'am, there is a classic triad of the pulsatile proptosis, conjunctival chemosis, and woozy sound in the head. In my case, ma'am, there is conjunctival chemosis and woozy sound in the head present and proptosis.
Yeah, very nicely answered actually. You told about the triad. I'm happy with that. And how early treatment is to be started for the CCF fistula? If the
Yes.
patient waits for 7 days, 14 days, so how early it has to be started? And surgical also, how early it has to be done? Any idea on that?
Yes, ma'am. Ma'am, some fistula carried out the great risk of the stroke in the future. So we should start treatment as early as possible. And ma'am, transarterial approach for the embolization is also done as soon as we diagnose the case.
Okay, so if this is done after 2 months, 3 months, do you think it's going to affect the results? What is the time period within
Ma'am,
which
should be
treatment?
done, ma'am, as early as possible, ma'am.
Okay, something like congenital cataract treatment you are talking about. Okay, thank you, Tusharni.
Thank you, ma'am.
Okay, 1 minute. You told that corticocavernous fistula type 1. What are the other types of this?
Ma'am, according to the Barrow classification, there is a type 1, 2, 3, 4, and in the type 1, there is direct connection of the internal carotid artery with the cavernous sinus. In the type 2, there is a connection between the meningeal branch of the internal carotid artery with the cavernous sinus. In the type 3, there is a connection between the meningeal branch of the external carotid artery to the cavernous sinus. And in the type 4, meningeal branch of the internal carotid artery as well as the external carotid artery connected with the cavernous sinus.
Okay.
Okay. So, any more questions for Dr. Tusharni? Okay. If there are no more questions, we'll move to the last speaker of today's presentation. She is from SIMS Bilaspur, Dr. Arushi Sharma, mentored by Dr. Prabha Sonwani. So, over to you, Dr. Arushi.
I have to inform that actually Arushi has just messaged me that something has happened in his family. So she won't be able to do the presentation.
Okay.
So we can just, yeah. So I think it's the competitive session 2 is over.
Okay, ma'am. Okay.
Okay.
So over to you, Meenakshi madam. Thank you so much.
I request all the judges to just compile the results and message it to me. So now I would invite and welcome Dr. Devi Aishwarya Das. She is the head of WOS Orissa, and she will enlighten us about Project Red. Welcome you, ma'am.
Thank you. Good morning, Dr. Meenakshi and the WS team of Chhattisgarh. Are my slides visible? Am I audible?
Yes,
Yeah,
ma'am.
ma'am.
Yes, ma'am. You're audible.
Yeah.
Your slides are also visible.
Yeah. So I'll be again talking about the Project Red. So Project Red, as you know, is the project on rare eye disease. So the journey of 1,000 miles begins with a single step. So did our journey in Red begin. So what exactly is this Project Red? Women's Ophthalmology Society initiated the following agenda: establish a national registry for rare eye diseases as well as rare aspects of common diseases. We would collect data on demographics, clinical picture, course, counseling, treatment collected and stored. Thus, the rare eye disease group was established in 2019. This is supported and funded by CIPLA. So this was the first publication from Dr. Mohit et al. In IGO about this Project Red. So what were the objectives of this group? To form a common cloud-based template customized to each disease under study, to give a common platform to all ophthalmologists, irrespective of gender, working in any sector, to record and report their cases, to find drugs or treatment modalities for these diseases from the existing therapeutics, as well as initiate new drug discoveries. This would enable all this, and to provide genetic counseling, rehabilitation, and support to patients and their families subsequently. So till now, what exactly has been done? The diseases have been identified. An ethics committee of WOS has been formed and the clearance taken. Investigators have been enrolled, but we are still taking in fresh investors. Team leaders and group coordinators have been identified. The pro forma for the patient data entry have been finalized. And all team leaders, coordinators, investigators, all are being sensitized via regular Zoom meets now. So for the data entry, a personalized link has been created for each investigator for the data entry. The team leaders can have access to the group data, only view. They cannot download or they cannot alter or modify. Then at the end of it, data compilation and analysis will be done, and a central repository will be created for all times to come. And so it's an ongoing project, though we have timelines to it, even then it's an ongoing project. So what are the rare eye diseases being taken up? Rather, what are the rare aspects of some of the common diseases that we have taken up? One is RP, Stargardt's, corneal dystrophies, ocular tumors, pediatric glaucoma, myopia, normal tension glaucoma. And the last, that anterior segment manifestations of COVID and posterior segment manifestations have now been kept on hold, the last one. So if anyone is interested, you can notify your state WS head or its Dr. Mohita, and then your name can be included as part of the investigating team. So we did have timelines, though we are seriously lacking behind. However, we intend to finish the data collection for the time being before the WOS annual conference. So for entering the data, as soon as you notify your interest to be an investigator, you will be given a username and a password to access the database. You can have your entry, you can enter your own data. You will not have access to any other investigator's data. Only the team leaders can have a view access to their team members' data. So this is how we are going on about Project Red. So data entry is now to begin. There are certain guidelines. You need certain consents from people who are working in institutes. Will need a consent from the institute head. People who have their own practice can of course go ahead, but they will still need consent from the patient to be included in the repository. It is not an intervention that we are doing anyways, but even then patient's permission needs to be taken before you can enter their data in the database, because at every point the patient should be able to be traced. Because suppose we are doing any genetic testing or any kind of genetic analysis, then the patient recall facility should be there. So for that reason, the patient's consent is a must before you use his or her data for this database. And as regards genetic testing and counseling, it is an objective of Project RED. It will also help create a national repository of the genetic basis of all the diseases that we are going to enter. Then genetic analysis to look into RED that still do not have a genetic diagnosis. This would perhaps help find drugs, treatment modalities for RED from existing ones, as well as to initiate newer interventions. Then, as an ongoing part of Project RED, we plan to take up genetic counseling, rehabilitation, and patient support programs. We plan to take up training programs in this. For this, we will have the technical support of MedGenome. And MedGenome has also assured that the genetic testing can be done at subsidized prices or even free if the patient that is being included in the database is known to be poor. So the woods are lovely, dark and deep, but we have promises to keep and miles to go before we sleep. Thank you all.
Thank you so much, Dr. Devi Aishwarya Das, for briefing us about the Project RED. Now I would request Dr. Bijita Deb to speak on dual polymer for dry eye. Dr. Bijita.
Thank you so much, ma'am. So I'll just share my screen. So am I audible and are my slides visible?
Yeah, you are audible and your slides are also visible.
Okay. So thank you, WOS, for this platform and the state of Chhattisgarh and Dr. Meenakshi, ma'am. So I'll just briefly run through this presentation sponsored by CIPLA. I'm Dr. Bijita Deb Paul. I'm a cornea anterior segment refractive surgeon consultant working at AB Super Speciality Eye Hospital, Raipur. So we will see today the dual polymer advantage in the management of dry eye. So as we know, dry eye is a very common entity and it is one of the commonest problem that we see in our day-to-day life, and the prevalence is expected to be somewhere between 5 to 33% of the adult population. So there are multiple steps or the multiple ways where we can manage a dry eye patient. It starts with a simple counseling, a proper questionnaire that we ask at our OPD level, and at the same time, starting basic lubricants to the patients whenever they complain of minor eye discomfort. Then moving on to identifying if there are any specific causative factor for dry eye, such as MGD, meibomian gland dysfunctions, any infections such as Demodex infection, if they're associated any systemic issues that we need to treat. And in severe cases, in association to topical lubricants, we might need to give oral supplementations like oral secretagogues, or we might need to give immunomodulators if the patient has any immunomodulator diseases. At the same time, ocular level, we can give certain other supportive treatments such as these scleral lenses, soft bandaged contact lenses. And in severe cases which do not get treated with just medications or topical drops, we might need to do certain surgical procedures, some temporal procedures like punctal occlusions, to advanced surgeries such as minor salivary gland transplantations. So we know that artificial eyes remain the mainstay of treatment in dry eye. So here is what we need to know about the multiple generations. So initially, when the teardrops started, it was just simple saline-based isotonic or hypotonic solution, which mostly had preservative back. But as the time evolved and as the disease evolved and as we evolved as medical practitioners, we understood that dryness is not, dry eye is not just a simple absence of tears. It has a much complex mechanism by which it affects our day-to-day life. So the next generation of treatment was methyl cellulose and synthetic polymers such as HP Gore, which had much gentle preservatives other than BAK. Moving on to the next third generation, where we are giving hyaluronic acid to most of our patients. But the next era has come where we need to understand that it is not just a simple supplementation of tears or artificial tears, where we are talking about artificial tears with a lipid component. So I'll be explaining about this in my subsequent slides. So these are the two most commonly used viscoelastic or viscosity enhancing agents that we are using in our day-to-day practice, that is the HP guar and sodium hyaluronate. So what we understand is that in a dry eye, there is inflammation. The inflammation leads to a more acidic pH environment. And as the acidic environment increases, when we are giving a patient with a drop which has HP guar, this HP guar has a quality where it will form a reversible cross-linking once it comes in contact with the surface of the eye, which forms a gel matrix. That gel protects the cornea and the conjunctiva. And at the same time, this HP guar polymer also binds to the hydrophobic site of the damaged epithelium of the ocular surface. So in addition to providing lubrication, it retards tear film desiccation, it enhances tear film stabilization, and serves as a natural bandage to allow repair of the surface epithelium. So what we understand is that it improves the retention time of the formulation. At the same time, it provides increased relief from the symptoms of dry eye. So it has a mucomimetic property. So this is how it acts. It provides a mucin layer. It leads to tear film maintenance, tear film stabilization. At the same time, it has a protective role for the corneal epithelium. So we know about sodium hyaluronate, and I need not describe that. Sodium hyaluronate is available both as in our body, and we can obtain it from natural resources. So sodium hyaluronate also binds to water effectively, and at the same time it resists dehydration, which promotes epithelial wound healing. And the viscoelastic property of sodium hyaluronate is what makes it a very common preference for topical lubricants. So as I have mentioned, the viscoelastic property is also addressed, or it is because of the high water holding capacity of the sodium hyaluronate. So how does sodium hyaluronate promote wound healing? It through fibronectin, an extracellular matrix protein, it stimulates epithelial cell migration and it accelerates corneal wound healing. It binds to this fibronectin and forms a sodium hyaluronate fibronectin complex, which leads to ultimate wound healing. So here the property of sodium hyaluronate is it imparts the viscous property of a liquid. At the same time, it imparts the elastic property of a solid. So the shear force between tears and the ocular surface is what how it acts. So as I've already mentioned, it has the viscous property at the same time, like the elastic property. So that's where we come to the combination therapy, where we think about the synergistic benefit of HP guar along with sodium hyaluronate. As we have mentioned, sodium hyaluronate has viscoelastic property and HP guar has a gel-like mucoprotective layer. So this helps in the pH helps in gelling the HP guar to the ocular surface. It provides prolonged lubrication. It has the mucomimetic property. It both accelerates in corneal wound healing. Sodium hyaluronate also imparts in the water retention due to its hygroscopic property. So all this helps as a dual polymer benefit in patients with severe dry eye, moderate to severe dry eye. So as we already know the multiple layers of the tear film, and as I have discussed, the HP guar has more of a mucomimetic property, and the sodium hyaluronate, in addition to its viscoelastic property, they form a synergistic effect for our dry eye patients. So there are multiple clinical studies that have been conducted which shows that hyaluronic acid and HP guar combination can significantly improve the tear film breakup time. This is another slide which is showing the same, where it improves the tear meniscus height when used together. 1/3 of the patient undergoing cataract surgery, we know complains of dry eye. So it has been found that if we start this combination or the dual drug therapy in patients preoperatively and give them postoperatively for 3 months, it has been shown that these patients do much better than just starting these patients on postoperative dual therapy or just using any other artificial tears or versus using no artificial tears. So the benefit of dual therapy is useful when we start it preoperatively, when we counsel our patient. So there is another slide showing the same where the tear film breakup time improves in this dual therapy. Again, this is another study showing how the dual therapy helps in protection of the corneal endothelium. So multiple studies have been conducted. So that's what is been showing in the subsequent slide. I need not read out all. So at the end, we need to understand that what is the key take-home message. The dual polymer tear substitutes provides increased tissue hydration and lubrication and protects the ocular surface from damage associated with dry eye. It helps maintaining the tear film stability, especially in our day-to-day post-cataract surgery patients. It provides significant greater cell viability than the individual single polymer formulations on a desiccated corneal epithelial cell. It helps in reepithelialization of the corneal wound by accelerated wound healing process. Thank you.
Thanks a lot, Dr. Bijita, for your informative talk. So now we have come to the end of the sessions, and I think all have been waiting for the results. The results are here. I'm not just announcing the results. So the winner of this WOS resident program is Dr. Sharmila S. from AIIMS, and her mentor is Dr. Vijaya Sahu. So we congratulate Dr. Sharmila and Dr. Vijaya ma'am for winning this competitive session, and I also congratulate and give best wishes to all the other presenters also. So now Dr. Sharmila S would be participating in the annual conference, which is in October 5 to 7 in Delhi. And she would be provided accommodation over by the WOS. So now we come to the end of this nice and informative session, and I would like to thank our President, Dr. Madhu Bhadoria ma'am, our Secretary, Dr. Mohita Sharma ma'am, who has given Chhattisgarh chapter this opportunity to present this resident program. And I would like to thank all the judges who have taken time from this busy Sunday for this residence program. I would like to thank all the presenters and their mentors who have done this hard work. And I would like to thank my executives and my moderators who have helped me so much for this program, Dr. Bijita and Dr. Amrita Verma. And I would like to thank all our guest faculty, Dr. Madhu Bhadoria ma'am, Dr. Jimmy Mittal ma'am, and Dr. Devi Aishwarya Das, who have given us and enlightened us by their talks. And last but not the least, I would like to thank Sipla, who have given us the technical support. And here, by this, we come to end of this program. And thank you so much, all of you.
Meenakshi, I would just like to mention one point. All the speakers were good. Their content was good. The PPT was good. Way of presentation was good. I think it was because of uniqueness and creativity that mostly, it gets an upper hand in most presentation these days. So because of that, I think the winner has got her name. So congratulations, Dr. Sharmila.
Thank you so much, ma'am. Thank you.
Okay. I would also like to thank Dr. Shweta Walia ma'am, who have been constantly helping me for designing this program. So now we can end this meeting.
Sure,
Dr. Shweta Walia ma'am, are you here? I think she has left the meeting.
Yeah, thank you, Meenakshi, Amrita, and Bijita. Wonderful job, as usual. And thanks for making me a part of this meeting. And I apologize, I could not, I think I thought that it is starting at 9:30. The presentations are starting at 9:30, so I had that in mind. But then it started a little earlier.
Yeah,
okay, anyways. Yeah, yeah.
Okay,
Thank
thank
you.
you so much, ma'am, and thank
Thank
you
you
all
so
of
much,
us for
ma'am.
joining.
Thank you. Thank you. Bye.
Bye.